Assalamualaikum and hi. Today I will present about Tartrazine induced asthma and urticaria.
Tartrazine E102 yellow number 5 is an azodide and a trisodium salt of 4,5-dihydropyroxo, 1,4-sulfophenene, 4,4-sulfophenene 1H pyrazole, 3-carboxylic acid, used as a food coloring to achieve yellow shade in sweet, jelly, juice, jam, mustard, and soda. Additionally, also used in pharmaceuticals such as vitamin capsule, antacid, cosmetic, and hair product. Now, we move to reaction of tartrazine in terms of compound. Tartrazine, a nitrous derivative, is transformed into a highly sensitive aromatic amine when it enters a liquoric azo class. Sulfonylic acid was discovered as the main metabolite. Tartrazine is known to elicit allergy symptoms such as urticaria and asthma due to its metabolic conversion into aromatic amine, sulfonylic acid, via the gut flora, and it has been the subject of research into carcinogenesis and mutagenesis. After intake and possibly through mammalian azoreductase in the liver or intestinal wall, the P415 enzyme system oxidizes this azodide to N-hydroxy derivative once they have been entirely reduced to aromatic amine. However, superoxide and ion hydroxy radical and H2O2 reactive oxygen species RS may be produced during nitrosamine metabolism and raise oxidative stress. Toxicokinetic study revealed that only 2% of ingested tartrazine is immediately absorbed, while the majority is broken down into smaller metabolites such as sulfonylic acid and aminopyrrolizone in the colon. The former metabolites can be absorbed to a greater extent than tartrazine and may be transported to other bodily systems, causing undesirable effects. Tartrazine-induced urticaria and asthma is type 1 hypersensitivity. Allergen enter the host cell, resulting in the activation of Th2 cell and the production of IgE antibody. IL-4 and IL-2 secreted by Th2 cells stimulate by B lymphocyte to switch from making IgM antibody to making IgE antibody. IgE antibody produced in response to an allergen bind to high affinity Fc epsilon Ri receptor expressed on mast cell. In the second exposure, when mast cells sensitized by IgE are exposed to the allergen, the cell mediated to secrete their mediator. Before that, mast cells are triggered by cross-linking of high-affinity IgE receptor by antigen bound to anti-specific IgE, by anti-Fc epsilon Ri alpha, or by anti-IgE antibody. Mediator produced by mast cell are histamine, vasoactive amine, and protease from granule. Histamine release peak at 5 to 10 minutes, followed by de novo synthesis of lipid-derived mediator, leukotriene C4, LTC4, and prostaglandin D2, PGD2, and cytokine. Urticaria is characterized by itchy wheal, angioedema, or both. Urticaria lesions resulting from localized edema of the upper dermis are called wheals, whereas pronounced whealing of deeper dermal layer and subcutaneous and submucosal tissue is known as angioedema. Acute urticaria lasts less than 6 weeks. It is common and often caused by viral infection. Chronic urticaria lasts more than 6 weeks with continuous disease activity. A cause may not be found. Urticaria occurring intermittently over a period of more than 6 weeks can be defined as episodic. This reaction causes blood vessel dilation and increases the permeability of the blood vessel wall, which means while blood vessel diameter increased, blood flow to the affected area increased. Fluid is allowed to leak out the blood vessel wall and get into the interstitium, the space between the cells, which causes edema and swelling, and urticaria or hive. Asthma is a common but complex clinical syndrome affecting people of all ages, characterized by variable airflow obstruction, bronchial hyperresponsiveness, and airway inflammation. Symptoms such as wheezing, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. After exposure to the allergen, the smooth muscle around the bronchiole start to spasm, and there is increased mucus secretion. This narrows the airway, making it difficult to breathe, and this is why asthma is considered to be the type of obstructive pulmonary disease. There is also increase in vascular permeability and requirement of additional immune cells from the blood. So, a few hours after exposure, this immune cell, particularly eosinophil, release chemical mediator that physically damage the endothelium of the lung. Initially, these inflammatory changes are completely reversible, but over the year, irreversible changes start to take place. Edema, scarring, and fibrosis build up, leading to thickening of epithelial basement membrane, which permanently reduce the airway diameter. Main test to diagnose for urticaria is skin prick test. It's performed by depositing drops of allergen on the lower forearm and reading the result after 15 minutes. Skin prick tests are the cheapest and the most effective method to diagnose urticaria. For asthma is FeNO test, you breathe into a machine that measures the level of nitric oxide in your breath, which is a sign of inflammation in your lung. Next is spirometry. You blow into a machine that measures how fast you can breathe out and how much air you can hold in your lung. Lastly is peak flow test. You blow into a handheld device that measures how fast you can breathe out, and this may be done several times over a few weeks to see if it changes over time. Treatment to treat urticaria is antihistamine and omalizumab. Treatment to treat asthma is inhaler and Tebutra. Inhaler have three categories, which are reliever inhaler is to treat symptoms, preventive inhaler is to reduce the inflammation, combination inhaler is to stop symptoms from occurring. For Tebutra is leukotriene receptor antagonist, theophylline, and steroid table.
Q&A session. What treatment options are available for tartrazine-induced asthma and urticaria? Treatment primarily focus on avoiding tartrazine-containing product. Antihistamine can help alleviate urticaria symptoms, while asthma medications such as bronchodilator and corticosteroid may be prescribed to manage asthma exacerbations. In severe cases, emergency medical attention may be necessary. How much dose of tartrazine is allowed? According to the Food Act 1983 in Malaysia, Food Amendment No. 2, Regulation 2014, if no standard is set, the approved food additive must meet the specification proposed by the FAO or WHO Expert Committee on Food Additive (JEFFA). In the USA, FDA maintained an ADI of 5 mg per kilogram body weight per day, while an ADI of 0 until 7.5 mg per kilogram body weight in the Europe. For its uses in European Food and Drink and JEFFA, an ADI is 0 until 10 mg per kilogram body weight.